My name is Tessa Buer, and today I'm talking about empagliflozin and UTIs. I am a PharmD candidate for 2021 at Drake University. So we'll start off with the mechanism of action. This is for all of the SGLT2 inhibitors. So they inhibit the sodium glucose transporter 2, which inhibits the reabsorption of glucose. These lead to the glucose excreting the body through the urine. So as you can see in the graphic below, the SGLT1 and SGLT2, there's about 10% of glucose reabsorption with SGLT1 and 90% occurs with SGLT2. So we're excreting about 90% of that glucose when we're inhibiting that reabsorption. So what are the consequences of this? So there's increased risk for UTI. There have been hospitalizations reported. So these have included the urosepsis, which is sepsis due to a urinary tract infection, and pyelonephritis. It's taken about 45 days for onset to occur with patients that have had these happen, so not too terribly long. We also need to think about our high-risk populations, so our elderly patients, 75 years and older, are at a much higher risk. They also are at a higher risk for if they're female. So due to the anatomy of a female's body versus a male, there is more surface area for bacteria growth, which leads to a higher risk for that urinary tract infection to occur. Additionally, renal function is something that we are always thinking about as pharmacists, and the worse of the renal function is, the higher incidence of the urinary tract infection could be to occur. So this is something we definitely want to keep in mind, as some of these agents can be considered nephroprotective. We just want to make sure that we are keeping in mind that it also can, even though it might be nephroprotective, increase the risk for that urinary tract infection as an adverse event. So there were, from the FDA Adverse Event Reporting Service, there were quite a few, or not quite a few, there were a few that were reported for hospitalization. There were 19 cases, and 15 of those 19 cases led to discontinuation of the SGLT2 inhibitor. So not necessarily only empagliflozin, but canagliflozin or dapagliflozin as well. So things that we need to double check before initiation of the medication, and then additionally continue to monitor while they're on it. So have they had a high history of urinary tract infections? Are the patients already at a higher risk? If they have constantly been battling urinary tract infections throughout their entire life, we maybe don't want to initiate this medication, because they're only going to be at a higher risk because of that to undergo even more urinary tract infections. Additionally, age, as I talked about before, so those greater than 75 are at a higher risk. However, those under 65 were also reported to have hospitalizations and urinary tract infections according to the FDA Adverse Event Reporting System. And then additionally, renal function. So not only is this something that we monitor initially, we don't want to initiate these medications in patients with an eGFR of less than 45 mils per minute. However, if their renal function is worsening while they're on the medication, it might be something to consider taking them off of, because it's only increasing that risk for the urinary tract infection and possible hospitalization thereafter. So what is the best for the patient? Do we always discontinue? Do we keep them on it? Well, that depends. So if they're hospitalized for the complicated UTI, we're going to probably discontinue it. They could be hospitalized for an AKI due to this medication, sepsis due to the UTI, or pyelonephritis. If it leads to a hospitalization, it's not worth it. So that medication should be discontinued. If the patient is treated outpatient for an uncomplicated UTI and we're relating it to the SGLT2 inhibitor, such as empagliflozin, we need to kind of evaluate the patient on a case-by-case basis. So was the UTI resolved with antibiotics? Is this the first incidence? Is it a recurrence? Is it worsening? Have they had more recurrences since the initiation of the SGLT2? Based on the answers to these questions, we would want to evaluate the patient and possibly discontinue therapy or choose another option. So for clinical judgment, pharmacists, we are always being the patient advocate. So just always thinking about should the initiation occur or should the therapy be continued. So if the hospitalized, would they be rather be hospitalized for uncontrolled diabetes or hospitalized for UTI? Well, maybe we don't need to be hospitalized for either one. If they maybe shouldn't be initiated on the medication, are there other options? Can we avoid the adverse effect that may lead to that hospitalization altogether and put them on a different medication? Maybe a DPP-4 or an SGLT2 or insulin even. These might be better options than some of our patients just due to the renal function and the adverse effects of those urinary tract infections. We also just need to be cognizant that if they have been hospitalized for UTI and we can somehow relate it to that SGLT2 inhibitor, such as empagliflozin, we probably want to discontinue that option and find a new diabetic regimen for that patient. Thanks for listening. That's all I had today. Hope you were able to learn something.